When does the clinical journey of a cancer patient end? Is it their last course of chemotherapy, their last radiation treatment, maybe 5 years cancer-free? In fact, for many patients, this journey doesn't have a clean endpoint at all. This is definitely true in prostate cancer, where follow-up, that is, monitoring a patient for any signs of recurrence of cancer, can routinely go on for decades or even a lifetime. Prostate cancer is the most common cancer in men, and the good news is that patients with the diagnosis are surviving longer than ever. But there's another side to that. The more patients who have a good response to treatment and who enter remission and who live longer after remission, the more the workload of follow-up becomes front and center in cancer care. To address this, we need to understand how prostate cancer follow-up is done today. It revolves around a quantity called the PSA. The PSA stands for prostate-specific antigen, and it's a protein that's made in the prostate where elevated levels of the protein are a marker of cancer. This graph that is coming up shows a typical PSA curve for a prostate cancer patient. You can see that it is going up, and that's when people first usually notice that they have a problem. So the PSA is elevated, they come in for diagnosis, they find out they have prostate cancer, and at that dotted gray line over there, that's when treatment happens. And if all goes well, the treatment is successful and the PSA level goes down again. If you've ever had a relative with prostate cancer, you'll be very familiar with what I'm saying. Now, if everything goes according to plan, that level is going to stay low and the patient will live healthily. But we continue to follow up, continue to check their PSA levels, and for some patients, it starts to creep up again. That's where that question mark is. Now, this increasing PSA level, that could be a sign of a recurrence of cancer. But the complication is, it could also be something called a benign PSA bounce. That's a totally benign increase in the PSA level that has nothing to do with recurring cancer, doesn't require any treatment, and goes away on its own. Now, if we mistake a true recurrence for a benign bounce, then we're going to delay treatment. We could allow, potentially, a curable cancer to progress into something we can't treat. On the other hand, if we try to play it safe and treat every single increase in PSA as severely as a recurrent cancer, well, that's going to lead to unnecessary MRI imaging, which is expensive, it's time-consuming for our clinical systems, and it leads to unnecessary anxiety. So how do clinicians today decide between these two situations? They use something called the Phoenix criterion. This is a very simple rule. All it says is, look at the lowest value of the PSA and check how much higher the PSA goes up after that value. If the amount of increase is above some threshold, then we call it a recurrence. That threshold is set exactly the same for everybody. No matter how young or old you are, no matter what stage of cancer you had previously, we always use the same threshold. This totally ignores individual patient characteristics, and it ignores the shape of the PSA curve. It doesn't take into account how quickly it's rising, what the slope is, anything like that. Now, experienced clinicians understand these limitations. They don't just use the Phoenix criterion to make a black and white decision. They incorporate that information together with what they understand about the patient. And this experience, this intuition is honed over many years, seeing many hundreds of patients. The more men a clinician sees, the better they get at this intuition to understand who is really in need of MRI imaging to confirm a recurrence. But the problem is, it takes many years to build up this intuition, and furthermore, no one clinician is going to be able to learn from every single patient in the population. That's why we've built the PSA Control Tower. The PSA Control Tower is an AI dashboard that does what no one clinician can. It learns from every single prostate cancer case in our population. How do we do this? First, we identified all the patients in Mayo Clinic platform's de-identified patient database. This includes everyone who's ever been treated for prostate cancer at Mayo Clinic and will soon include many other health systems from all across the world. Secondly, we use large language models to automatically read hundreds of thousands of clinical notes and extract key clinical features from them. This is a kind of work that would have been impossibly time-consuming before the advent of generative AI. Finally, we train an AI model to take in all of these clinical features along with the shape of the entire PSA curve for all of these patients, and from that predict what a true recurrence is and distinguish it from a benign bounce. Our model runs automatically every time a patient receives a new PSA measurement. Our results show that it can correctly identify a true recurrence up to a year earlier than the Phoenix criterion can. Again, that could be the difference between curable and uncurable cancer. All of this is presented in a single dashboard that tracks follow-up for every single prostate cancer patient at Mayo Clinic. This dashboard allows you to see the most recent PSA, the probability of recurrence according to the AI model, and it automatically flags anybody who's got high risk of recurrence or is maybe missing their most recent PSA measurement. There's no more falling through the cracks of follow-up. We envision that once this dashboard is live, one person is all it will take to manage all prostate cancer follow-up at Mayo because everything is centralized and automated. In closing, zooming out, I think this is how all follow-up for long-term care should be. Predictive, not reactive, unified in a single dashboard at a glance, not scattered between different departments and providers. This control tower provides a template for how we're going to manage the coming surge, not only in prostate cancer, cases of which are going to double by the year 2040, but in all long-term care. As our societies age, more and more of our resources are going to be spent on follow-up and management. Things like the control tower are how we're going to continue to deliver the best care in the world decades after a patient leaves our doors. Thank you.